Good afternoon, everyone, and welcome to the Community Partners in Action Education Series. This is actually our last session today of our 5-week program. And for those of you who are joining us for the first time, I will be sending out an email if you are registered with today's recording and any information that Tricia passes on to us. And if you're by chance not registered and I don't have your email address, feel free to just put it in the chat box and I can pick it up and make sure that you get the information. So before I introduce Trish, I would like to just share something with you that I sent out this morning to anyone who was registered. And I sent you a bunch of information with regards to dementia-friendly resource kits. These are kits that our group put together. And so I wanted to make sure that you had the option if you want to make those for people that you are supporting living with dementia, or maybe family, friends, or colleagues, or within your workplace, that you are welcome to utilize all of those resources to be able to make those for other people. So if you have any other questions with regards to that, like I said, I sent you all an email with this information and this is what they look like. And I'd be happy to have that conversation with you at a later time. So I think we're going to get started. I don't like to hold up Tricia too long here, but I want to introduce you to Tricia Tetz. She is a recreation therapist with Alberta Health Services. She also is a behavioral consultant, and she has been wonderful giving us some information over the past 5 weeks about supporting people living with dementia. And I have to say they've been fantastic presentations. So I'm going to mute myself here and let Tricia take over.
Well, thank you so much. I'm very sad that this is our last presentation together, and hopefully there'll be an opportunity to do them again or do different ones even. So today, for our last but not least presentation, we're going to be talking about responsive reactive behaviors in dementia. So responsive reactive behaviors are terms that are commonly used to refer to actions, words, gestures, presented by a person who's living with dementia as a way of responding to something that's negative or frustrating or confusing in their social or physical environment. So some examples of responsive reactive behaviors include things like aggression, whether it's verbal or physical, could be bad mouthing or talking about people. Oh, the staff here is always mean. Oh, my husband has been stealing money from my purse, those kinds of things. Whining or complaining a lot. And this isn't about stuff that's made up. It's about stuff that is made up. It's not real things that are happening, because people are allowed to complain if they have a genuine concern, but it's continual and it's not usual behavior for that person. Constant requests for help. Sometimes in facilities, we have residents and they are, help me, help me, help me. And you go over there and you're, yes, Mary, how can I help you? And they're like, hi, how are you? You're like, good. Are you okay? Yeah, I'm fine. And you walk away and they're like, help me, those kinds of things. Swearing or ugly words. So curse words, ugly words are things that people use like fatso, loser, moron, those kinds of things are ugly words. Grabbing onto people and not letting go. Racial slurs, confabulation. We talked about this in the last presentation, where their mind will fill in details that are missing, so they absolutely 100% believe that it's true. Insomnia, mixing up days or nights. Paranoia is something that can happen a lot when people have dementia. Refusing personal care, that's a huge challenge, especially in the mid to mid-late stages of dementia. Screaming or calling out. Rummaging through things, rummaging through closets, packing things, unpacking things, rummaging through your purse, rummaging through suitcases, just making, kind of putting everything everywhere. Exit seeking, or we call it elopement, when people are trying to leave the building and we're concerned that something bad will happen to them and we can't get them back in. Agitation or irritability, especially when it's not their normal personality. Anxiety is another one that comes up with a lot of dementia, reactive response behaviors. Calls to 911, these happen quite frequently, a lot to do with confabulation. People have made up a story in their mind, or their mind has made up a story, so they're going to call the police because it needs to be taken care of. General restlessness, toileting issues, losing, misplacing, hiding, hoarding items, making strange noises, sundowning syndrome, withdrawal socially, or sexual language and touching. These are all really common examples of what a reactive responsive behavior could be. But in a more general term, it's a behavior that's causing distress for either the caregiver or the resident, that's not in their normal behavior patterns of behavior. So when we're looking at responsive reactive behaviors, we need to figure out what's causing this behavior, because the person who's living with dementia isn't able to tell us, oh, I'm in pain, for example, and that's why I'm hitting people. So we need to be a behavioral detective to try and figure out what's causing this reactive responsive behavior. So if you think of a time when, maybe a resident or a patient or a child had a meltdown, like an absolute kind of collapse. We don't just want to dismiss that as they're being a brat. We want to actually figure out what's causing them to act like this, what's causing them to have that meltdown. So there are 10 primary unmet needs, because it's usually an unmet need that is causing a reactive responsive behavior. So Teepa Snow's divided them into two categories. There's 5 physical unmet needs and 5 emotional unmet needs. So we have intake as one, we have energy levels as another, elimination, comfort, and pain. For emotional, we have anger. So when you're feeling angry, sadness or depression, loneliness, comfort, and boredom. And boredom's a big one. We'll get into that. It can be really challenging to figure out which unmet need the person is experiencing because the symptoms overlap continually. There's no set, if they're acting like this is the problem. We really have to figure it out. And it's going to be a lot of trial and error. And as long as your goal is to help that person, we can forgive any mistakes you might make. You might be sure it's that they have to go to the bathroom and you do everything you can to get them to go. And it's actually not that. It could be that they're in pain or something, or vice versa. So just go easy on yourself, relax, give yourself time to try and figure out what that responsive reactive behavior is. It is going to be a bit of a guessing game. So the first unmet need that we're going to talk about today is intake. And intake includes everything that goes into your body, including foods, fluids, and medications. A lot of people don't realize that medications, of course, go into your body. Foods, liquids, and medications. So intake is absolutely crucial. If you think of a time where you didn't eat for 5, 6, 8, 10 hours, how did you feel? If you're anything like me or like most people, you're probably actually hangry at that point where you get angry because you're hungry. And that's no different for our clients. So when we don't get foods or fluids properly, we can experience things such as agitation and aggression, being confused, a little bit more disorientated. We could have anxiety when we don't get enough to eat. We get kind of that tornado in our tummy, and that bothers us. Constipation can happen when you're not getting enough food or the right kinds of food, or you're taking a medication that causes constipation. Extreme fatigue. You can't function when you're that fatigued. Cramps. Headaches. If you don't eat enough or drink enough, you can get really bad headaches. Visual changes happen. Your eyeballs will actually change according to your blood sugar levels, especially if you're diabetic, and that'll change how you see things. So if you already have dementia and your vision is changing, it can bring on hallucinations or paranoia because you're seeing things that aren't there. That's why we're always like, push fluids, push fluids. It's really, really important. So medication issues are things like refusing medications when residents absolutely, or someone who's living with dementia, absolutely refuses to take their medication. They're like, no, I'm not taking that. It could be because you're trying to poison them. It could be because they don't know what it is and why you're trying to get it into them. If you've crushed up pills and put it into yogurt, it might have a sour or bitter taste to it. Why would they want to eat that? That's disgusting. Or that gritty feeling. They're like, no, no, I don't like that texture. I'm not taking that anymore. Skipping medications, especially if they are sleeping in longer, they miss their morning medications, that could be a problem. Or if they're living at home and they just forget to take them, that's a big deal. Getting the wrong medications, mixing up the medications that they're supposed to be taking. Now, hopefully, if they live in a facility, their medications are being given to them and double checked. But if they're at home, they could be taking the wrong medications at the wrong times, and that can cause a lot of issues. Maybe they're not getting enough of the medication. A lot of times we see this with residents, and we'll talk about their behaviors, and I'll ask about pain. They're like, oh, they get scheduled Tylenol, but Tylenol's not going to cut it for the amount of pain they're in. So they're not getting enough of the medication they need. Or the incorrect taking of medications. If they're not supposed to take medication with food, or if they are supposed to take it with food or not with dairy, no, they're not following all of the instructions because they can no longer follow all of those instructions. And antipsychotic medications, are they appropriate for the issue or the reactive response behavior that they're having? Refusing medication, that's a duplicate. Over medicating. Sometimes they're getting too much medication. This makes them drowsy or more disorientated. And that can make life a lot harder for them as well. So, medications are a very powerful tool when they're used correctly. But when there's an intake issue for medication, we can experience things like flu like symptoms if you have withdrawal. And right now, with COVID going on, nobody wants any extra flu like symptoms at all. They could have blurred vision, could have constipation or even diarrhea. They could be dizzy, they could be lethargic, they could have insomnia, they could have blurred vision, they could have mood changes, they could have hallucinations. So that's why it's really important to try and get the correct medications into them at the correct times in the correct manner. Next unmet need here is energy. So as dementia progresses, we are unable to self-regulate. And this is really important because we spend years teaching children to self-regulate their emotions and their body. And this is something that we actually learn our entire life, how to self-regulate, because our body changes. Right. So all of a sudden you might need more sleep. So you learn to self regulate so that you get more sleep. It's a very important construct. And remember, we talked about this in other presentations. A person who has dementia, their brain regresses very similar to how a child's progresses. So they're going to lose that ability to self-regulate, just like a child would gain that ability to self-regulate. When looking at reactive responsive behaviors in relation to energy levels, we want to specifically look at several different things. We want to identify things like, what do we know about their personal history? This is critical to helping decipher an unmet need. You need to know that person's history. This is great if you already know the person, if you're a daughter, a wife, a husband, a sibling of someone who's living with dementia. But if someone's living in a facility, the people in the facility usually don't know that person's history. And you want to ask questions about them, get to know your resident. When somebody comes into the facility, so their daughter comes in to visit, you're like, oh, you're Mary's daughter. Tell me one thing I would never know about Mary. Tell me something about her childhood. Every time, one little nugget of information. Often the recreation department does an amazing job at getting a really good detailed history on the person. So that'll give you a good insight, because sometimes one little clue to that person's past gives you the insight you need into why they're acting the way they are. So we want to know like who they are, what they like to do, where they grew up. All of those kinds of questions are really important to getting to know who the person is and helping decipher what the reactive responsive behavior is. What are their personal preferences? What does the person like? Again, this is really important. We tend to forget this. A lot of times I'm with a resident and I'm like, oh, let me grab you a cup of coffee. And they're like, oh, I don't like coffee. I'm like, but I see you with coffee every morning there. And they're like, well, yeah, the staff just likes to give me coffee and I don't want to complain. So I just drink it anyways. And so we need to know, do they like coffee in the morning? Do they like tea in the morning? Do they like hot chocolate in the morning? What is it that brings them that sense of peace, that comfort? I mean, a lot of people, if they don't get their morning coffee, they're really mad. So if you're giving them tea or juice instead, it's not going to set their day going the way that they've always had their day started. So we might get responsive reactive behaviors later on. Something else we want to know is, are they someone who likes routine, or are they a free spirit? Are they type A personality or type B personality? And there's no right or wrong answer. Type A personalities, they get things done. Type B personalities, they love to have fun. We need all of those people. But some people function best when their day is completely laid out for them, when there's a schedule, when there's a routine, when they know exactly what they need to do and when they need to do it. Some people, however, need space and time to be creative in how they spend their day. So if you take like a type A personality and just say, okay, go have your day, they're going to be lost. They're going to be like, this doesn't make any sense to me. What am I trying to do? And they're going to be asking questions. They're going to be following you. They're going to be saying, can I do this? I need this. I need, help me, help me. But if you take someone who is that free spirit and we try and schedule every part of the day, they're up at 7, they have a bath at 8, they have breakfast at 8:30, they're going to feel pressured. They're going to have like that anxiety closing in on them. So we need to know what works best for them. We also need to know what opportunities they've had to be active today. And I don't just mean physically active, although that is really important. It's every day. If there's a facility, there should be exercise programs every single day because people need to be active. But we also need to be emotionally active, because if you go the entire day without experiencing those normal emotional highs and lows, then your day gets very monotonous, or you start craving that little bit of excitement, especially if you're that free spirit and you need that little boost in emotion, a hug, a smile, that really good belly laugh that you used to have when you talked to your friend at 3 o'clock every day on the phone, right before the children got home. Those kinds of things. We need emotional highs and lows, emotional opportunities to be active, as well as physical. Also need to know what stage of the disease they are in. This is critical because a lot of times we just say someone has dementia, but we don't know where they are in that stage. And one of the other presentations we had, we talked about the gemstone models. We need to know, are they maybe a ruby? Are they an emerald? What can we expect from this stage of dementia? As dementia progresses, the brain actually produces less of the hormone acetylcholine, and the brain needs this for synapses to communicate between each other. So in addition to this, the brain cells themselves start shrinking. So you have the brain cells shrinking, and when they shrink, they pull away from each other. That means the acetylcholine that goes between the synapses, it gets lost, and there's larger spaces for it to travel. So if we know where they are, we know what kind of memory loss to expect, we know what responsive reactive behaviors they might be more prone to experiencing. Messages get lost in the brain because the brain can't communicate within itself. And a person who's living with dementia isn't able to recognize when, say, they're tired, or when their body needs to rest, or even when they're thirsty, or when they're hungry, or when they're in pain. So knowing that those cells are no longer communicating with each other might help us understand what responsive reactive behaviors we can expect in that stage. Then there's sleep quality. What is their sleep quality like? The quality of sleep deteriorates as people get older. We have less slow wave sleep, and that's just as important as REM sleep, rapid eye movement. So someone with dementia might be sleeping as much as 14 to 15 hours a day, but it's unlikely to be quality sleep. So they might be getting less sleep than if someone was sleeping 3 or 4 hours a day. And remember that the brain is hoarder. So every day as we go through the normal day, debris builds up in our brain, dead cells, like some beta amyloid proteins, which can cause plaques, which can cause dementia. They all kind of gather in our brain. When we get a good quality sleep, our brain flushes all of that out. We wake up, we feel refreshed, we're getting ready to go. When you have dementia and you're not getting quality sleep, your brain's not being flushed. So this is yesterday, and this is today, and this will be tomorrow. So your brain is hoarding all of that debris. And all of a sudden you wake up and you're really, really foggy. It's like you've had the worst sleep of your life. Because your brain hasn't had a chance to flush all of that out. And when you're not able to think clearly and rationally because all of that debris is there, you're going to have more reactive responsive behaviors. And we also want to know, what were their sleep cycles like in their past and what are they like now? So a farmer probably lived by the adage, early to bed, early to rise. A teacher, however, would have a very different sleep cycle. They might go to bed, different times. Someone who is a night nurse has a very different sleep schedule. So, I mean, a lot of times I have people that are like, oh, she's not sleeping at all. And she wakes up and she follows us around all night. And I just do like 3 minutes of research. I'm like, well, she was a night nurse. Yeah, she's going to follow you around because she's used to sleeping all day, being up all night. This is her sleep pattern for her entire working life. And of course, she's going to follow you around because that's her job too, right? She's probably, making sure you're doing your job right. So it's important to know also to think in 10-year segments because our sleep cycles often change about every 10 years. When you have little children or teenagers or young adults, or they've moved out of your house or you're retired, you sleep differently. When you're retired, you might suddenly start to take naps every afternoon. Or maybe you're someone who never took a nap and we're trying to get this person to nap in the afternoon. They keep trying to get out of bed and it's frustrating because they're tired. They need to sleep, or at least we think they do. But that's not their sleep wake pattern. So it's not going to work for them. Let's move on to elimination. And this one's the yucky one. And there's a lot of barriers surrounding this unmet need. And this one is the most private one that people don't want to talk about or they're embarrassed to talk about. And a woman, for example, is probably much more uncomfortable speaking to a male care partner about her bathroom toileting bathing routine than she would be to another female because we've been raised, especially older generations, we don't talk about our elimination needs. We don't have to say, oh, I have to go poop now. We keep that to ourselves. So if someone's calling out, help me, help me, help me, and it's because they have to go to a bathroom and a male care partner comes over, they're going to stop. They're going to clam right up. So it can be really hard to talk about this as an unmet need. People have been raised to keep this a secret because it's embarrassing. So several reasons that communication around toileting or elimination can be more difficult includes things like dementia progression. As dementia progresses, the person who's living with dementia might actually lose the ability to verbally explain or to express that they have to go to the bathroom. So instead of saying, can you help me? I really have to pee. They might just be, help me, help me, help me. One experience that I had is there was a lady and she was sitting there going, help me, help me, help me. So I went over and I took her hand and I'm like, I could try to help you. What could I do for you? And she's like, I want to go home. I want to go home. So I said, oh, is there something you want to do at home or do you just want to be there? And she goes, well, I don't really know, but if we pass the bathroom on the way, I need to stop. So her calling out, help me, she had to go to the bathroom. Took a little bit of questioning to figure out that's why she was calling out, help me, because she couldn't actually say I have to go to the bathroom until I led her in the right direction and it made something click for her. Also, a person with dementia might actually lose that physical sensation of being able to recognize what the body's telling them to. So again, the brain regresses the same way a child's progresses. And we train children to learn and recognize those signs, those sensations in our abdomen or in our lower back that say, oh, I have to go to the bathroom, and to hold it and to get to the bathroom. But as the brain is regressing, they lose that ability. So they're no longer able to recognize that they even have to go. They go because they can't express that they need to get there. A person who's living with dementia might also have completely lost their ability to control that bladder or bowel function, but they might know after an accident occurs. And because emotion is one of the strongest memories, embarrassment takes over. So people start hiding their soiled clothes. So sometimes we'll see people in a facility and we'll go in and they'll be cleaning their room and there's a whole bunch of dirty pads or underwear under their pillow. And often it's because they've had an accident and they've recognized that had an accident. So they remove the soiled clothes, but they don't really know where to put them because this isn't their home, it's a facility, or they don't know where a laundry basket is, or they just don't want people to know. So they're just going to tuck them in here and they're going to wash them later. So nobody knows. But then, of course, they have dementia and they forget that they were going to wash them. So they're under there, they're under the bed, or they're in the bottom of the closet for weeks until they're found. And people are like, why would you do that? But it is a very normal reactive responsive behavior for someone who's living with dementia. Also, as dementia progresses, our sense of smell and touch are affected. And that's either because of the physical decline or because our brain no longer recognizes those sensations for what they are. And when accidents happen, a person who's living with dementia might not be able to smell the offending odor. So you can walk in, you're like, oh, we need to change you, Mary. And Mary's like, no, we don't. Doesn't smell in here. Also, the longer we're exposed to a scent, any scent, whether it's good or bad, the less in tune to it we are. So we almost become accustomed to it. So the person who's living with dementia no longer smells that offending odor, or they can't identify where the source of that odor is, or they just don't feel the discomfort of being wet or being soiled. So an example of this is, if you see a resident or someone starts pacing about 20 minutes after lunch every day and they're asking, I want to go home, I want to go home, I want to go home. We want to find a way to figure out what their behavior is. So we could be like, well, they've just eaten about 20 minutes ago. Maybe that stimulated the digestive system and they need to go to the bathroom. We need to look for nonverbal cues or what they cannot communicating, what they need, and what behaviors they're exhibiting, the responsive reactive behavior. That's when the detective work comes in and it's trial and error to see if elimination is the unmet need. Maybe a scheduled toileting routine, following exit seeking, we can put in their charts. If they're exit seeking, please try toileting immediately. Those can be very, very helpful. Some other tips to assist with toileting as an unmet need is please remember that toileting is a private issue and needs to be treated discreetly. So often I hear, people calling across the hallway, or can you come in and help me change Mary? She's dirty again. Or Mary, do you need to go to the bathroom? Nobody wants that yelled across the dining room. It's embarrassing and emotion stays with us. People won't remember what you said to them, but they will remember how you made them feel. So if you make them feel embarrassed, they're not going to be able to trust you and turn to you when they're wanting to express what their unmet need is. So remember that it is private and that we want to treat that person with the ultimate respect and discretion. Approach is everything. For some people who are living with dementia, you might want to get really close to their ear and whisper it, let's go to the bathroom. Other people, you might not even want to mention using the toilet until you're physically into the washroom. You need to use your knowledge of that person. If I say bathroom to them, is that going to scare them? Are they going to start denying it? But if I'm in the bathroom and I'm giving them visual cues to go to the bathroom, then they might just go along with it. So remember to use a proper approach for each person, and it's going to be different and individual for each and every resident or person living with dementia that you're working with. This is again where knowing their personal history and knowing your client kicks in. I had a great experience with this. I was talking to his son about his dad, and he goes, "Well, I don't know if you really want to know this, but my dad's day was governed by his bowel routine." And I just kind of laughed. I'm like, "I actually do. I really do want to know this information." He's like, "Okay." He goes, "Because every day he'd come home at 5:30, and at 5:45 he would spend 20 minutes in the toilet." And that was his daily routine. I'm like, well, that's good to know, because if his body is programmed to have a bowel movement every day at about 5:45, we can put that in his care plan and we can assist him with that. That is amazing to know. And a lot of people don't think to share those kind of details. And when you're toileting with someone, remember to give visual cues before verbal cues. One particular lady I was working with, she was very nonverbal, and toileting was a real challenge for her. She didn't like to be soiled, but she couldn't get to the bathroom. She couldn't express that she had to go to the bathroom. And she would put up a really big physical fight when people tried to change her. So I went in one day and I took a pair of underwear and I held the underwear up and I said, bathroom, bathroom, bathroom. So I'm giving her the visual cue of the underwear, and then I'm giving her the verbal cue of telling her one word of what I want her to do. She kind of looked at me, walked right into the bathroom. She let me change her. It was wonderful. Didn't work every single time with her, but I always tried that because that visual cue for her, was really big. You also might want to give them a visual cue of mimicking sitting on the toilet or pulling down your pants or pointing to the toilet or showing them a picture of the toilet rather than going straight to verbal, because they're going to read your visual cues much more quickly than they're going to give or read your verbal cues. So, are you questioning your own knowledge about that person? What are their patterns associated with a certain behavior? Do you notice that Mary, every time she says, help me, and it gets more and more panicked, that she is going to need to go to the bathroom? Are we sharing this with people? We need to share it so that people know what's going on. So it's not just you that knows when Mary yells, help me, it's actually going to the bathroom. We want everybody to know that that's Mary's cue that she wants to go to the bathroom. When you are taking someone to the bathroom, always do with them, never to them. So never just take them into the bathroom and try and pull their pants down. That is going to be very detrimental to them. They're not going to understand. All they're going to see is you being inappropriate and trying to undress them. Help them, get them to do it as much as possible. Communicate with them. Use a lot of eye contact, hand under hand. I wish this was in person so that we could actually practice hand under hand for toileting. Google the Teepest No videos on hand under hand for toileting, because when you're holding their hand and you're using muscle memory to get them to do things like pulling their pants down, even if you're moving their pants, but their arms are going through the motion, it clicks better for them. And they're going to help you, and they're going to understand it's muscle memory, automatic autonomic reflexes that they've had their whole life. So always do with someone and never do to someone. It's really scary. If I just grabbed you and pulled you into the bathroom, started taking your clothes off, you'd probably want to fight me too. And this leads us to the misinterpretations of actions, especially when toileting, bathing comes into play. Because when we just take someone into the bathroom and we start undressing them, then these can be misinterpreted as us being sexual towards them. So then they respond in kind, because usually if you're with someone who's taking your clothes off, that's someone you trust, you respect, and that you're probably intimate with. So a spouse, for example. And so if someone's doing that and you reciprocate, and then all of a sudden the staff is like, oh, whoa, inappropriate sexual behaviors here. Really, it's them misreading how we have approached them. So it's really important to recognize that. A lot of people are like, oh yeah, no, they were sexually inappropriate. I'm like, oh, well, what happened? Well, I was giving them a bath and doing pericare. I'm like, okay, let's back up a moment. Was it really them being inappropriate, or were they just not truly catching what you were actually doing? So when this happens, because it will happen with a lot of people who are living with dementia, stay calm and just explain to them what you're doing. So just say, no, bath time, cleaning, giving them that one word, those responses. If they say something inappropriate, remember, that's a right brain thing. It's not their fault that it's coming out of their mouth. They would have never said that in a normal circumstance. Just explain to them, I'm here to help take care of you. I'm not your wife. I'm not your husband, that sort of thing. And don't take it personally. Remember that their advances or their comments are usually a response to the task that's actually being performed on them. So instead of us stepping back and saying, oh, I don't like the way that they said that to me, we need to think of, well, how did they interpret what I was doing to them at that time? comfort as an unmet need, this is one that usually gets overlooked the most. We forget that people really need to be comfortable, to feel safe, to feel secure, to feel protected, to feel like they want to be involved. And we truly tend to forget to investigate where a person's comfort level is. We just think their basic needs are being, met. They're getting food, they're getting medication, they're getting sleep. They're be able to breathe. They should be good. They should be comfortable. But we need to investigate because comfort level is so much more than that. We need to be asking a lot of questions as to who that person really is and what makes them comfortable. We need to ask a lot of questions. Again, this is where your recreation department, and if you're in a facility, can investigate that a little bit more. They can call the family, they can call the spouse, they can call the children and ask, has this behavior ever happened before? What's something that we can maybe do? What makes them comfortable? Those sorts of things are really important. So, depending on how uncomfortable someone is, they could experience or act out in ways that show that they're minorly agitated to full out physically aggressive. If someone, for example, what if you had a pressure sore on your heel but no one had really found that yet, and every time you walked you were in pain, and someone came and they're like, hey, let's walk to the dining room. You can't communicate that your foot hurts, you're uncomfortable, so instead you might just push out or punch or try and yell at them, go away, get out of here, leave me alone. And we don't understand why, but it all comes down to basic comfort levels there. And remember that comfort can be both a physical need and an emotional need. We'll talk more about the emotional needs in a little bit. Think about what makes you comfortable. How do your comfort needs change throughout the day? What's one thing you need every morning to make you feel comfortable? If anyone wants to unmute and tell me, that's great, or you can put it in the chat box and someone could read it out to me. Something that you need first thing in the morning to make you comfortable, to make sure your day goes as you've planned it. I know one thing that usually gets said is coffee. They need their coffee in the morning.
And that's in the chat box.
Of course it is. It always is. Other people say tea. I've had people say a walk. I go for a walk first thing in the morning, and that's what sort of clears my head and makes me get ready for the day. Some people like to have, they get their tea and their toast and they go out on their porch, or, they snuggle with their animals, those kinds of things. What do you need first thing in the morning? And what do you need throughout the day? Again, people often say more coffee. But, a lot of people think when you get off work, do you go and do you work out? Is that something that you need so that you can get rid of that stress so that you can be comfortable for the evening? There's so many different things for so many different people. And we forget that when someone has dementia, they still have that need for comfort. They're just not able to express it the way they used to be able to do it.
So a few more in the chat box, or are they warm enough?
Yes.
Not to be rushed. Their
Oh,
hygiene
yes.
and a
Mhm.
hot water bath. And order in the room.
Absolutely. The bath is a really important one, especially when it comes to bathing someone. Different generations have different views on bathing. So were they the kind of person that had a bath every Sunday night and that's the only time they bathed? Or did they bathe Saturday night so they were clean for church on Sunday? And suddenly we're trying to get them into a shower on a Tuesday morning. It's going to really mess them up. They're going to be very uncomfortable with this shift in routine. Some people like a bubble bath every single night. That relaxes them. Other people, if you try and give them a bath, they're like, I hate baths. I'm a shower person. Comfort is so important. We don't realize how much of our emotional intuitivity comes from us being comfortable. So, other considerations that we want to take into account, are they an extrovert or an introvert? So, imagine if you're an introvert your entire life and suddenly you're in a facility and you're in a common room all day with people walking in and out and they're touching you and they're talking to you. And you're like, this is too much for me. I just want to go sit in my room all day. Or what if you're an extrovert and suddenly you don't have any interactions or meaningful interactions with people? You're going to be missing a lot too. That's going to make you uncomfortable as well. What are people hearing? Are they missing consonants that we're saying to them? Is everything just a jumble in their minds? They're not getting the message. It's really uncomfortable. Have you been in a situation where, someone says something, you're like, pardon me, they say it again, and you still can't hear it. You're like, pardon me, and they say it again, and finally you just smile and nod because you're going with what's probably the most appropriate social response. You actually don't know what they've said. So if someone's coming up to you and they're, saying something, and finally you just smile and nod, and all of a sudden they're trying to pull your pants down, your comfort level is gone. There's no way you're going to be able to get them into the bathroom because they haven't heard that communication and you've made them really uncomfortable. Maybe they're only catching 3 out of every 4 words that you're saying. So you say, let's go to the bathroom, and they miss bathroom, let's go have a shower, and they hear, let's go pick some flowers. Those are going to have very different reactions. Impaired hearing also falls into the pseudo-dementia category. So watch for things like, are there multiple sources of sound in the room? There's a TV going, the radio's going, there's beeps going, there's other people calling out, a million different things. People cannot focus. What music is playing? This is really important because so often the staff play what the staff like. I remember once I was sitting in my office and I was really enjoying the music because it was Bon Jovi. I'm like, oh, I'm reliving my 80s days here. And all of a sudden it clicked. I'm like, why am I listening to Bon Jovi? Because there's no way the residents want to hear Bon Jovi. They want to hear the songs, Dolly Parton, those kinds of songs that they're going to recognize. Music plays a big impact. We need to pay attention to the music that's being played, and it needs to be geared towards what the residents will respond to bring out positive interactions. Could you imagine if you were playing like heavy metal to our residents? It would actually agitate them. It's really important. Remember that too much stimulation in a room can be just as bad as not enough stimulation. So we need to make sure that things are calm and set up for the individual residents' needs, not always the staffing needs. We also want to know what they're seeing visually because that's going to affect how comfortable you are with something. So mid or early to mid-stage dementia, we have scuba vision. So normally our peripheral vision is if you put your arms straight out to the side, you wiggle your fingers, kind of bring them in a little bit till you can see them. When we're really young, they can be back farther. As we get older, we come in, then it kind of, goes to here. And then when we get dementia, our peripheral vision changes to what we call scuba vision. So it's like wearing a scuba mask. This really changes what you see around you. However, with scuba vision, you can still do 2 tasks at a time. You can eat and be social because, you can see your food on your plate and you can see the person across from you. And then dementia progresses even more and we go into binocular vision. So now when you have binocular vision, you can only do one thing at a time. You can no longer be social and eat because you cannot see the person and the plate and the food at the same time. And then as dementia progresses even more, we have monocular vision, which is where you are really only seeing out of one eye. And that's before you throw in any other eye issues, macular degeneration, cataracts, anything like that. This is just purely the dementia progression that changes visually. So that's going to change your comfort level. When you take away peripheral vision, so you have binocular vision and someone kind of pops in front of you, you haven't been able to see them coming. It's going to scare you. Your brain is going to go into fight, flight, or freeze mode. And it's going to change how you react for the rest of the day because it's going to take a long time for that cortisol that's flooded your brain, the stress hormone, to be able to clear and for you to relax a little bit. Also, as dementia progresses, people no longer see in 3D, and we don't always realize this. They start seeing in 2D, and this is about mid-stage dementia. And 2D is like how you see things on a television set. So if you're not able to see things in 3D and you're going to reach for something and knock it over, it's a little bit scary. Well, why did I knock that over? Or you're seeing the television, but because it looks exactly the same as everything else, then you are going to maybe think what's happening on TV is real. So that's why we want to be careful about what TV shows are playing in the background, because we don't want someone to think that someone was really murdered on a train. We want them to know that they're in a safe, friendly environment. Sometimes like female talk shows are really good for that, because then it feels more like people are just sort of all gathered around. I know like Homes and Gardens programming is very, very popular because it's calming, it's fun. It feels like you're going through this nice new house, those kinds of things. So visual changes are also really, really important for comfort. So next time you see a responsive reactive behavior, think, could it be their comfort level? What's going on that makes the environment unsuitable or uncomfortable to them? What's going on emotionally? What's going on in the environment around them that's making them uncomfortable? Pain. So for quite a while, it was believed that as dementia progressed, people actually lost the ability to feel pain. Thankfully, now we know this isn't true, and we've come to understand that someone who's living with dementia experiences pain exactly the same as before, maybe even more, because of different changes in the brain. Maybe their nerves are more sensitive. The difference between a person living with dementia and a person not living with dementia is that the person not living with dementia can recognize and express the pain that they're in. So do not confuse the ability for a person to talk with the ability to recognize and express pain. I remember once I was in a meeting and one girl said, "Oh no, he talks all the time, and I'm sure he'd be able to tell us if he was in pain." So I had to say, well, not necessarily, because pain is received in a different part of the brain as communication. So his communication center might be unaffected, but maybe the center that controls that pain response is affected, and they're not communicating between the two. So they could still be in a significant amount of pain. Now, there's not a lot of stats on how many people living with dementia have undiagnosed pain, because we would assume as soon as pain was diagnosed, they'd be given appropriate pain medication. But what they have done was a case review study. So they took all of the charts of people with hip surgery. So all of these people had the exact same surgery, and they did a chart review. The people who are living with dementia actually received 1/4 of the amount of pain medications, but what they did receive was 3 times the amount of antipsychotics. So these people were experiencing the pain that everybody was, but it wasn't coming out like, "Ow, ow, ow, ow." It was help me, or them trying to get out of bed, or trying to move, or trying to do things. And the people were like, "Oh, they just won't stay in bed. They better give them an antipsychotic." So we want to step back and say it could be pain causing this reactive responsive behavior. If you're in pain, you're going to be protective of your body, and you're going to smack out if someone's trying to hurt you. So from this one statistic, it does seem pretty obvious that responsive reactive behaviors were not being identified as pain. And rather than exploring the reason beyond the behaviors, the patients were simply medicated or sedated into behaving. And the sad thing is even with the sedation of the antipsychotic, they're still feeling the pain. So now they're feeling the pain and they're drugged up and they can't express it. It's just, my heart breaks for them, because they weren't being considered, their behavior wasn't being considered as responsive or reactive. You know who is really, really good at diagnosing pain in nonverbal patients? Veterinarians. Veterinarians are great at that because none of their patients can talk. So when we're looking for examples of pain in residents, we want to look for things like facial grimacing, just those different faces that people make when they're in pain. If you just think about, the last time you had a really bad headache, what facial? What did you do? How would you express that you had a headache to someone if you couldn't say anything at all? Gestures that indicate distress, sometimes like holding on to an arm or a leg, guarding that body part, moaning, ow, with or without movement. They could be rocking back and forth. Rocking is a stimulation. It actually takes all the fluid in your brain, and that rocking motion, that's why you rock a baby. It's actually very soothing for us. So they might be rocking themselves back and forth. Limited range of movement or slower movement than normal. Oh, they're trying to get out of bed, but it's taking them 15, 20 minutes, and they're, maybe throwing a punch now and then. They're probably in pain. It hurts to sleep. It hurts to wake up when you get older. They could have increased heart rate, increased blood pressure, or maybe they're sweating. Sweating with seniors isn't as common because they tend to sweat less in general. That's why bathing actually can be less of an issue than we think it is, because they actually don't produce that body sweat as much as someone who's younger does. General restlessness. It amazes me how someone can be in so much pain and still walk and walk and walk. Had one resident, and she had a hip fracture, and she forgot that she had a hip fracture. So she'd get out of bed and walk. She'd be in so much pain, but the walking was the only thing she could think of to do because it was her hip. So I think maybe in her mind, she was trying to stretch it out or relax it, but trying to keep her in bed was such a challenge because she just wanted to walk and walk and walk. That's a sign of pain. They needed to up her pain medications. Moaning or crying, of course. Increased or decreased vocalizations. Decreased is really important. Sometimes we forget that because when people get really quiet, we think, oh, they're all good. They're not calling out. But sometimes when you're in a lot of pain, we get more quiet, and that can be a big sign too. When they withdraw socially and they self-isolate and they stop doing things that they used to do because they're in pain, they may not realize, oh, I don't want to walk down to that activity because it's going to hurt. They just are like, no, I'm just not going to do it. They could be lethargic, or they could be sleeping a lot more. Sleep is a big way that a lot of people deal with pain. Could be the inability to sleep, or they keep waking up constantly. That's another one. They could have a decreased appetite. They stop eating when you're in pain. Sometimes you feel nauseous and you just cannot and will not eat. Increased confusion. When you're in pain, you are not your best self. And so your confusion is increased. And sometimes we just think, oh, it's just their dementia, because we don't notice that it's suddenly a little bit higher, a little bit higher, a little bit higher. We're like, oh, it's just a normal progression. But we still need to think pain. They could be agitated. They could be angry. They could be aggressive. They could be completely irrational, because when you're in pain, like I said before, you are not your best self. You do not make good decisions when you're in pain. So when we're looking for pain, when responsive reactive behaviors are brought up for pain, the very first thing that I usually do is look up a person's medical history. And this is really important because not only am I looking for a specific dementia diagnosis, so I know if there's sort of the classic reactive responsive behaviors are there for the symptoms, but I also want to know the whole picture. I want to know things like spinal compression fractures unhealed. A lot of times those things get missed. Oh, they've had, unhealed spinal compression fractures their whole life. Well, yeah, they probably medicated themselves for their whole lives with Tylenol or Advil or maybe something stronger. What are we currently giving them? We're like, oh, well, they get, Tylenol twice a day. That's probably not going to cut it for compression fractures. They're calling out, help me, help me, help me. And it's in relation to pain. We want to know that whole story. I've had things like one gentleman told me, yes, he had grown up like in Amsterdam or somewhere. And when he was young and newly married, him and his wife were hit by a train, and he had broke his back, and he was in the hospital recovering for 2 years. He had significant back pain, but no one at the facility knew that, because that actually wasn't even in his chart. So us knowing that, we're like, yeah, this guy's probably having pain. He's dealt with pain his whole life. Sometimes those things just get missed for whatever reason. The family didn't think about communicating it because it's so normal to them that the staff didn't know. So we want to know the whole picture. Also want to know if there's things like neuropathy, so like nerve damage due to like diabetes. As a lot of times I've had people, they're like, oh yeah, no, they have neuropathy in their feet. Like, oh, what are they getting for pain? Oh, they're getting Tylenol. I'm like, does Tylenol help with that kind of pain? They're like, oh no, not at all. I'm like, oh, so we need to give them something else probably. And we're like, yeah. So then all of a sudden they're on an appropriate pain medication for what they're experiencing, because Tylenol doesn't really touch nerve pain. It's good for general pain. Um, so we want appropriate medication for the pain that they're experiencing. There's also pains like pressure sores, ulcers, foot problems, and then also consider the pain that might not be in the charts. Things like if they have an ear infection, I'm prone to chronic ear infections. How would I let someone know if all of a sudden overnight I developed an ear infection? People might never know, but hopefully my children will have said, oh, my mom gets ear infections about, every 3 months or so. So if all of a sudden she starts getting really, really cranky, really upset, really angry, check her ears. Toothaches, headaches. What if you're prone to headaches? Lots of people are. And people don't know this, they're not going to give the extra Tylenol to help fight that headache. What if they have had arthritis for 20 years, but now it's progressing, so they're having more arthritic pain, and we just assume their pain level's always been where it always was? Pain changes as we get older. So when I do a chart review and I have a referral for certain behaviors, I always ask questions like, well, when did this behavior start? What happened around that time that this started happening? What happened before the responsive reactive behavior? Did they have a fall a day or two previous? Those sorts of things. Has this behavior happened in the past? Because sometimes it's happened and people have dealt with it and forgot to sort of make a note that they acted this way when they were in this kind of pain. But knowing that information, oh, well, they're acting the same way. It's probably pain. Ask family about it. Is this new for them? Have they ever had this or done this or acted this way before? Is there something that works for them? Oh yeah, my dad liked a cold compress on the back of his neck when he had a headache. Little things like that, comforting things. Again, we're going back to comfort as an unmet need. They're also tied into each other. It's kind of amazing. Did you do a pain scale on them? And sometimes it's hard because asking yes or no questions, people might deny they're in pain because their brain isn't communicating. The pain part isn't communicating to the communication part that they're in pain. So they're saying, no, I don't have pain, but they have a significant amount of pain. So we need to do more than just a yes, no, on a scale of 1 to 10, where would you put your pain? We want to do more of a visual pain scale, a responsive reactive behavior type pain scale. So things like this are incredibly important for us to know. Because, sorry, I'm skipping ahead of myself a little bit. These things are incredibly important for us to know because we need to be able to look back on the behavior for that person. Now we have anger as another unmet need. So why can a person with dementia get so angry so often? Mostly because when we get stressed, our brain produces a stress hormone called cortisol, and it affects how we react. So cortisol is a stress hormone and it changes our behavior. Again, cortisol puts us into that fight, flight, or fright mode. So it's really great to have your brain flooded with cortisol if suddenly, a giant spider comes running out from under your bed so you can react and kill that spider, but not so much in daily life when we're trying just to live. Cortisol is there for a reason, but when we experience it in a different situation, it causes a responsive reactive behavior. Even as a person who's not living with dementia, when our brain floods with cortisol, we lose the ability to be rational and logical. That's completely diminished. We cannot respond as our best selves. When we get angry, our brain floods with cortisol, we lose control of our emotions. And this is in the very best of times. So, with the amygdala being responsible for our perception of emotions, and this includes things like fear, anger, sadness, pleasure, the ability to control aggression, that's the kind of thing the amygdala controls. Also, when we're looking at anger, it's crucial to have that life story. We need to have the life story because we need to know what their baseline behavior is. Maybe this person's always been an angry person. So then it's not a responsive reactive behavior, it's a personality. But if, he was always the sweetest gentleman and he held doors open and he complimented people and he was funny and compassionate and caring, and all of a sudden he's angry all the time, then that's a responsive reactive behavior. So we need to know what's normal for them and what's not normal so that we know that it's a problem. So if a person who's living with dementia has their frontal lobe affected and they're no longer able to regulate that self-control, that's going to be a big deal for someone. Or if they think something mean or aggressive, they're just going to say it. That's where those ugly words come in. If they see something and they don't like it and they're going to call you, you're such a moron, you're such a loser, you're an idiot, those kinds of things. Sorry, give me 1 second. Didn't know if you could hear that, but my Roomba just started going off and I needed to turn it off. So if the frontal lobe is affected and we're no longer able to control or regulate and be logical, then when something pops into their head, someone is going to do it. So if it pops into your head to hit someone, they're going to hit someone. If they pop into their head to swear, they're going to swear. So dementia, again, is both chemical and structural. So the acetylcholine that goes back and forth, as well as structural abilities to control our anger, is going to come and it's going to go. And again, this makes people think that maybe they're faking because yesterday they were in complete control and now today they're losing their mind. What is going on? They know better. They can do better. But it's not. It's simply a progression of the disease and the fact that dementia is fluid. So understanding that dementia physically causes anger is half of the battle. The other half is just because someone is living with dementia doesn't mean that they don't have normal mood swings, pet peeves, and triggers just like everyone else. A lot of times we expect that just because someone has entered community living or care facility, that they're always going to be their very best selves. But that's not true, not true at all. It can be extremely challenging to suddenly being in a supportive living setting because all of a sudden, your whole life has changed, especially if you're an introvert and you're around people all the time. So it can be extremely difficult to be around people all of the time. Having people walk into your room constantly, losing that privacy, that can be frustrating and embarrassing for people. Another thing I see a lot, and this causes so much stress for residents, is staff telling you what to do all the time. Sit here, do this, get up, let's go to the bathroom, time to eat. Those little things, you need control in your life. Or even worse, there's nothing for you to do, just go sit over there and watch TV. You think you're being nice and helping them, but they want to be productive. That's important. Not having enough productive activity is huge for people. So we need to remember that when a person's living with dementia, we're as people, we are programmed to be productive. We need productive activity. Then there's sadness, and depression is a condition in which people feel sad, hopeless, or irritable most of the time. And irritation, though, is often overlooked as a sign of depression. Sadness or depression is extremely common for people living with dementia due to the vast amount of changes and losses in their lives and that loss of independence. So things like irritability, anger, disinterest, sending people away are all in fact classic signs of depression for people who are living with dementia. People with dementia or depression, also experience anxiety and feelings of social isolation. So the number of people with depression rises at over the age of 65. And up to 70% of people with dementia will experience a significant depression at some point. Depression can make symptoms of dementia a lot worse as well. So, for example, depression can lead to increased forgetfulness, confusion, and anxiety, which also is a sign of dementia. So it just builds on top of each other. And it's important to diagnose depression in people with dementia because depression may respond to treatment. Depression in dementia, or people living with dementia, don't tend to respond as well with medications. That's because the brain chemically has changed when you have dementia, but it is still important that we want to try that. The symptoms of depression can be similar to dementia, making it more difficult to identify depression. But there are some common signs of depression that we want to be aware of. So things like loss of previously enjoyed activities, loss of energy, sleeping problems, increased confusion, weight gain, loss of appetite, weight loss. So look for those changes or things that are out of character for the person who's living with dementia. Those are often indicators that something is off with them, and we need to start investigating why. Loneliness. This is a big one because it is really common for a person who's living with dementia to experience loneliness, but it's usually overlooked or ignored, particularly for people who are living in care facility settings. So, yes, they see people every day, all day, but connection is more about meaningful interactions with people. It's not simply being where other people are. And that's really important because we tend to forget that, oh yeah, no, she's always in the dining room. But if she's not connecting with anyone, she could still be lonely. People always get the care they need to survive, but they don't always get the care they need to thrive. And that's what we want for the person who's living with dementia, is that ability to thrive. So this is even more true for people who are natural introverts. They don't want just anybody around. They only want their people around. So let's take meals, for example. Meals, menus are kind of set to certain guidelines set out by Health Canada, set out by the facility. People are brought in early to a dining room and they sit in silence and they eat their meal and they eat in silence. The only kind of communication is maybe between staff or a little bit between staff and residents. There's a lot of thought given to the food they eat, given to how they're eating it. Is it minced? Is it pureed? Is it soft chew? Is it diabetic diet? All of that is given a lot of thought, but the environment isn't given a lot of thought. How they're going to eat, how are interactions encouraged? Is there music playing? What music is playing? At the very least, every dining room should have music playing during meal times. That's just good for digestion. It can be lonely, very lonely to sit and eat in absolute silence every day, and the only conversation is occurring around you between staff. What are people used to? Small meals, big family dinners, cafeteria style 3 times a day isn't going to meet their need for connection. And what if you don't like the people that you're sitting with? So a lot of thought, again, is put into what they're eating, but we need to focus on how they're eating. Connection is not just about not being lonely. Humans need to connect on an emotional level. Offering to help is another attempt to connect with people. And we see this a lot. Our residents come up after lunch. Can I help with the dishes? Can I help wash? And, we're like, no, you go sit. We think we're taking a load off them because they don't have to wash dishes. But they're trying to connect with you. They're using that offer of help to say, please let me know that I'm valuable. Please let me know that I'm still needed, that I have something to offer. They're looking for that connection, and we're missing that cue a lot of times. Offering to help clean up after a meal, helping with the project. It doesn't matter what the activity is. It's the interactions that are important. Group settings does not automatically equal connection. Connection is what we need, though, to combat when loneliness sets in. So according to the Alzheimer's Society in the UK, 61 50% of people with dementia feel lonely. And this can be in part because they no longer have a group of friends or family, or maybe they don't remember their friends and family have just visited. But connection, it does not have to be with just friends and family. In fact, in supportive living, research is showing us that connections with staff and other co-residents, but primarily staff, that connection with the staff is what's absolutely critical. So we want to look for words like, when I'm getting a responsive reactive behavior, things like attention seeking, exit seeking, where are they trying to go? What are they trying to do? Depression, anxiety, agitation, wandering, sexual behaviors. When I read these in a referral, I automatically put loneliness or connection seeking at the top. And we have to remember too, when people are lonely and have dementia, they can't express that they're lonely. Maybe they don't even recognize that they're lonely. And we want to change attention seeking to connection seeking. They're not actually looking for attention. It's not that annoying, oh, they're attention seeking. No, they're looking for a true emotional connection with people. Sometimes the connection isn't always with the person that they're looking with. Sometimes it's a connection with a place or a thing. Did they live on a farm, or do they connect with the outdoors? Are they an animal lover? Do they connect with animals? Or maybe it's trying to connect who you were back then with who you are now, dealing with the changes that when you're going through. So remember, we want to change that. And residents and people living with dementia are no longer attention seeking, they are connection seeking. Now we have fear. Fear is a big one for people who are living with dementia. People become anxious or scared when things are unknown, and that's just human nature. It's human nature to worry. And it's human nature to be upset and to have anxiety, and our fear, and dementia will actually exacerbate these symptoms. It can be really scary not knowing who's wandering into your room or your private space. You have moved in a facility, you have one room, it's usually a bedroom, and people you don't know are constantly coming and going. That can be really scary, especially if you have had any trauma in your past. It can be scary not to know where your next meal is coming from. I hear this a lot, especially people who are like, I don't have any money with me. That's terrifying. I don't have any money. How am I going to pay for this? That's, causes a lot of anxiety. That's a big thing. Feeling you're trapped or locked in a room, you're suddenly in a locked unit and you can't get out. That's going to be terrifying for people. Having personal care performed on you by strangers. If I just walked up to you right now and started giving you a bath, you'd probably be really, really scared. Not knowing where your family is, especially if you're lost in time or place and you think you have little children, nothing brings out that mama bear in someone, like not knowing where their children are. Not being able to communicate what you need. Your brain might know, but you're just not able to get that thought out. So how are you communicating to people? The loss of communication is terrifying. Or people not understanding what you're saying when we're getting word salad from people and they're like, I threw a pancake in the river. I threw a pancake in the river. And we're like, okay, go sit down. Yeah, no, that's good. No, we don't need any pancakes here. They know they're not communicating properly, but they can't figure out how to communicate properly. And that's frustrating. And that's very, very scary. When we get older and we have to use a walker, it's really scary to feel like our next step could cause us to fall. It can be really scary if our hands and legs and feet aren't working the way we want them to, the way they used to. It can be really scary not knowing where you're going to sleep. This is a very common question. Oh, I need to go home. I don't know where I'm going to sleep tonight. Can you help me go home? Can I come home with you? Where am I going to sleep tonight? No, we have a room for you here. You sleep here. You live here now. That's just going to exacerbate their fear. We need to calm them and relax them and make them feel safe. can be really scary when someone comes into your room at night. A lot of places just call them night checks, but sometimes people are just in that twilight sleep, or they have, they're not in that REM sleep. They don't have a good quality of sleep. So something clicks when they hear the door open and they kind of wake up and all of a sudden someone's in their room. That's really scary. It can also be scary just to be sat at a table for a meal with people that you don't know. That's going to be a big one for some people, especially if you're an introvert, because if you're an introvert, then you don't want to be around a whole bunch of people. Then there is boredom, and this is a big one. Did you know that for people living with dementia, their largest complaint is boredom and loneliness? That's a big, big thing to understand. That is what bothers them more than anything else, is being bored and being lonely. And these two things go hand in hand. And so, why do boredom and loneliness top the list? It's usually because caregivers are at a loss of how to actually provide dementia related care. This is important because it's not something we just know, and there's no manual for it. It's something that you pick up on as you work with that individual person. Dementia symptoms have changed the relationship between caregiver and loved one, and it's common to feel at a loss for what to do with them. So when you can no longer have a conversation with mom like you used to, or dad's agitations have made visits with him feel very negative, children can, and you can understand why they would start to pull away. Our interactions start to become limited to personal care. And that's the problem. The person is still there. They still need that love. They still need engagement, and they still need attention. And it's up to us to adjust our methods in ways to adjust our methods so we can find new ways to connect with them. The care partner role demands a lot of creativity, and it's so critical to provide opportunities for people who are living with dementia. In fact, it is so important to provide these opportunities for engagement that there's an entire field built around this, often serving seniors and people living with dementia. So when people don't have enough activities to keep them busy during the day, a lot of responsive reactive behaviors occur, specifically ones like sundowning, resistance to care, agitation, paranoia, increased confusion. When people don't have enough meaningful activities to occupy their mind and find things to do, because as people, we are programmed to do meaningful activities. If they don't have enough, they're going to find their own. And that can be a little bit of a problem because those activities might not be safe, they might not be helpful, and they can cause problems in the long run. So for people who are living with dementia, it's not just as simple as, oh, I think I want to go and do this activity. I'm going to go and do that. We have lost that initiation and that sequencing ability. So it's very hard for people to just do. Activities need to be programmed. Facilities need engagement activities, or the homes that a person who's living with dementia lives in needs engagement activities, activities that people can pull out at any time to engage a resident. Some of these activities, and these are great because you can keep them, and once you have them put together, they can be at a place where they're accessible by everyone. You can pull them out and you can do them over and over and over again. Have a big jar of coins. A lot of facilities that I worked at, any coins that would go through the laundry and we didn't know who they were, they would go in a jar so that we could sort coins together. And that could be something. You could start sorting coins. Oh, I'm going to leave this to you. I have to go do this. You keep sorting those coins. Sorting jars of buttons, PVC pipes. You can go to Home Depot, you can get those big long PVC pipes with connectors. It's like a giant Lego set or erector set. Those are great. Putting photos into an album. It doesn't have to be their photos. They could be anybody's photos, and you can take them out of the album and the next day they can be put back in. Pencils or pencil crayons to sharpen. You know what? The kindergarten, they really need all these pencil crayons sharpened. Can you sharpen them for me? Music stations, dishes to wash, cleaning supplies, vinegar and water. It's not going to hurt anything, and they feel like they're doing something. It's actually amazing how many people like to clean. I don't know. I think there's something wrong with them, but some people like to clean. And if all of a sudden you're not able to clean anymore, you're going to miss a little something out of life. So let them clean. Boxes to sort through or rummage through, helping them set tables for meals, jewelry boxes to go through, send out in a newsletter, please donate all your old jewelry for dementia programming. Sorting seashells. You can buy a lot of amazing seashells at the dollar store. Stickers in an album, reports or resumes to go through, coupon clipping, sorting decks of cards. This is great because it's nothing to mix up a deck of cards. Toolboxes with nuts and bolts, wood blocks to sand, coloring sheets, puzzles, laundry. People have a love-hate relationship with laundry, and they like to fold. And this is a big program. Even you get bonus points if you put it in the dryer first, so they get to fold nice warm laundry. Sweeping the floor. Some people will sweep the floor for hours. It doesn't even have to be dirty. You could hand them a piece of rope with a whole bunch of knots put in it, and they can try and untangle the knots. That's great for working, finger dexterity, as well as they think they're helping you by getting rid of all those notes or all those knots. Items with different textures. Fidget toys are not just for children. We should have a container of fidget toys for every person with dementia, things that they can fiddle, especially if they're in that go, go, go mode. They need things to touch and things to do. So easy crafts, if you can set them up, they can continue them. A box full of fun fabrics. This is a big one. They can prepare food. They can slice bananas. They can butter bread. Get the banana, have them mash it. Doesn't matter if the banana gets thrown out. Doesn't matter if they eat it. But they're feeling productive, and that's the only thing that matters. Sorting cutlery. You buy bright plastic forks, knives, and spoons at the dollar store. You mix them all up. They have to sort them. It's great. They really feel they're accomplishing something. So tips for making engagement activities personal, those are great general ones. But if you're looking to design an activity for someone specific, you want to ask questions like, what did the person do for work? What are their current strengths and abilities? What can they still do? Because you want to make it a positive experience. What supports do they have? Can family put these together? Will families bring them in? So many amazing families out there. They can't do enough. They just don't know what to do. So if you say, can you pick up like 10 packs of colored cutlery so we can sort them with your dad? Absolutely. They'll be all over that. You probably end up with 60 packs and share them with the whole facility, because some families really, really want to help. What hobbies did they have? Were they a coin collector? Were they a stamp collector? Did they like to sew? Could they cut out patterns? All those little things. What did they like to do? What currently makes them happy? What makes them happy in this moment? What are their current cognitive abilities? You want to design a program or an activity that they're going to be successful in. If it's hard and frustrating, it's not going to work out very well. What are their current motor abilities? What's their fine motor? What's their gross motor? Can they do little crafts that need to be big general movements? Those sorts of things. What are their social skills? Do they like to be with people? Can they still converse with people? Do they interact well? Do they have a sense of humor? Do they like to tease? What senses do they like to focus on? So when you think of senses, it's, your sight, your sound, your smell, your taste, your touch. Where are they focused on in there? So do you want to do a sensory program with smell, or do you want to do a sensory program for touch? What's going to make them happy? What stage of their dementia are they living in? What time and place are they living in? And what time and place are they living in? So when we're trying to engage people in activities, we want to invite the resident. Don't just assume they're going to go. Even if you've asked them 25 times and they said no 25 times, the one time that you don't invite them is the one time they might have went. So always invite, never assume. Demonstrate how the activity happens. Remember, they've lost that initiation and that sequencing ability. So we might need to get them started. So if we have coins, we pour a whole bunch out. We're like, oh, here's all the quarters. And you start sliding the quarters out. And you're like, can you see a quarter? So really get them involved. Demonstrate how to do it. Ask for help. A lot of people like to help people. They won't do something for themselves, but if you ask them to help you, they're going to help you. Could you sort these cards to me? Or cards for me. I need them for the next program and I just don't have time. I need all of the different card suits laid out. Can you do that for me? Break it into really small steps. Don't just hand them a deck of cards and say, can you sort these cards? Just say, oh, can you flip all the cards over? And then you go on to the next step. Oh, do you see any diamonds? That kind of thing. Little itty bitty steps. Offer the person something to touch or hold. Remember, especially as dementia progresses, we start working primarily on out of our senses. So often the sense of touch is really important. Again, that's where fidget toys come in. What feels good to touch? Thank the person for helping, because you know what, if they spent all that time helping you and you just take it for granted, they might not help you next time. Thank you so much, Mary. I couldn't have done this without you. You're the absolute best. Can I come back tomorrow and would you help me again if I need it? It's going to be really important. Remember to offer choices. Would you like to do this or would you like to do that? Not, hey, Mary, do you want to do an activity? No, no, no. Mary, would you like to sort cards or would you like to help me sort coins? I need them both done. This or that, this or that. Avoid activities that reinforce inadequacy. Make sure it's not overstimulating. This is really important for people. Consider timing of the day. If someone has sundowning, that's when you might want to do one activity, a calming activity, but you might not want to do, something that's a little overstimulating. So that's really important, is the time of day that you do the activity on. And remember, most important thing is to focus on the process of the activity, not the end result. What we end up with, if it's a giant mess, it can go in the garbage, but it's how they felt while they did the activity. So that's all I have today. Thank you guys so much. If anybody has any questions, please feel free to shout them out.
Can you quickly demonstrate that hand under hand thing?
Okay, it's really hard because I don't have a volunteer. And my hands don't bend, but basically hand under hand is if you're reaching to shake someone's hand, and instead of shaking their hand, because it's when someone gives you your hand, it's an automatic autonomic reflex to reach back to shake their hand, because we've been raised, that's appropriate, it's polite. So when they give you permission to touch them, to shake their hand, you're going to take their hand, this is where it gets hard, and hook it around. So basically, this part right here and that same part of their hand are touching, but you're kind of connected. But I'm not able to show it on my own hands. Please, if you want a really good demonstration, Google Teepa Snow hand under hand. It's like a 5-minute video. They'll walk you through the whole thing. It's impossible to show because my hands don't bend that way. But it is really one of the most effective ways to get someone to guide someone who's living with dementia, because you're working off of automatic autonomic reflexes and muscle memory.
Thank you.
Well, I think we're a little out of time. Thank you
I'm
so
sorry.
much. That's okay. And lots of information, which is great. And the nice thing is, what we tend to do is, once Tricia sends me the PowerPoint, I email it out to everybody, so you can rewatch these things and access them. We also put it on the Wolf Creek Primary Care Network so that you can see the videos anytime you want, or you can share it with family or friends or whomever. And but first of all, I want to thank Tricia. That was fantastic. The last 5 weeks and all the information and the little tips and tricks and everything that you've shared with us has been phenomenal.
It has been my absolute pleasure. And I just thought I'll attach the link for the Teepa Snow video in the information I send to you.
Okay.
Then people can just click on that.
Yeah, that sounds great. I will get that all sent out next week. And like I said, once I send it out, if you'd like to share that with other people, please feel free to forward that on to others so that they have the same opportunities to learn as well. So thank you very much for attending, everyone. And I hope you have a terrific weekend.
Have a wonderful weekend. Thank you so much, everybody. Goodbye.
It's really good.
Thank you.